She's formerly the associate professor at the University of Texas, MD Anderson. And now she's chief of the section of the GI Medical Oncology at the University of Arizona Cancer Center. She has served to be several committee members, including ASCO, ASCO GI, SWOG, and NCI. And the title of the talk will be The Downstage Locally Advanced Disease. Rachna, please.
Thank you very much, and thank you to the organizers for the kind invitation to speak and to meet and collaborate with all of the fantastic researchers in this room. So as mentioned, I'm going to be talking today a little bit about downstaging locally advanced disease, and as you can imagine, there is not a lot of randomized phase 3 data that we're going to be discussing, but I think it will be nicely synthesizing a number of the different points that have been touched on over the course of the day today. So I always start with a slide that reminds the people in the room about my perspective as a medical oncologist. So as somebody who treats pancreatic and biliary cancers every single day, as you can imagine, I pride myself on being an optimist and fully believing that there is hope and progress in moving the needle forward. And I think that we are starting to see that, as I'm sure you've seen over the course of the day today, in terms of better understanding cholangiocarcinoma, realizing that it's not one disease, and figuring out how to use that information in our strategies towards locally advanced disease as well. We've already seen these slides, but I just always put it up to remind everyone that these are different diseases. But I think similar to what Dr. Primrose said earlier today, for now, I think lumping is probably reasonable in the sense that we need to be able to answer these questions in systematic trials. And the reason that I put this slide up, which we also saw earlier today, is to just remind everyone that while we in the U.S. consider this a rare disease, I don't need to tell this room that this is actually a global problem with a much higher incidence in this part of the world. And as you will see, there are some studies looking in the neoadjuvant space that are ongoing in the eastern part of the world, and I think it's an area that is ripe for collaboration between the two groups. I think it's also important to remember that as this is increasing in incidence, intrahepatic cholangiocarcinoma seems to be the primary instigator in that in terms of the shift in epidemiologic trends. And as a result, when we're thinking about locally advanced disease and neoadjuvant approaches, we are probably talking more so about intrahepatic cholangiocarcinoma as time progresses. So just a quick primer and reminder on localized disease. I think we all know that surgical resection is the standard of care and is the only curative therapy that we have available for intrahepatic cholangiocarcinoma. And that we know, as we learned earlier today, that in R1 disease, there's probably a role after resection for chemoradiation, but that the role of adjuvant therapy in R0 resection was debatable until our UK colleagues challenged that paradigm. And so I borrowed these slides from Dr. Mithal, who kindly provided them for me. But the point of bringing up these slides is to show that even with surgical resection, we're not really hitting it out of the ballpark in terms of survival rates, both for hilar cholangiocarcinoma as well as intrahepatic cholangiocarcinoma. And so we already discussed the adjuvant treatment. There's a number of trials that have been completed and reported, and as of today, the BILCAP study is the one that has been reported as positive, and the ASCO guidelines are out that are recommending 6 months of postoperative capecitabine. This is that study that Dr. Primrose already spoke on, and as he mentioned, I think it's important to notice that there is a substantial survival benefit. While it did not meet significance in the intention to treat, it is still a number to aspire towards, frankly. So then that makes me ask the question, when we think about biliary cancer, sometimes I think we extrapolate from the pancreas world. And in the pancreas world, when we treat patients in the metastatic setting and we find combinations of therapies that actually work in that space, we shift it. We shift it to adjuvant, we shift it to neoadjuvant. And so then, of course, there are questions in the biliary world of should we be using these types of chemotherapies that we're using in the adjuvant and metastatic settings? Should we be using that in a neoadjuvant approach for patients that are, as have been previously described, as borderline resectable or high risk or locally advanced? Well, as we know that in the advanced setting, gemcitabine and cisplatin remains the standard of care based on the ABC02 study. It has yet to be surpassed in terms of that median survival that we've seen time and time again of 11.7 months. I think in this study, one of the things that was noted, if you see here that the locally advanced population, which was approximately 100 patients, there was a benefit that was notable and striking in terms of using doublet therapy compared to gemcitabine. So then the question becomes, should we be looking into chemointensification? You know, in the pancreas world, FOLFIRINOX became a standard of care in the metastatic setting, and at first it seemed crazy to give these patients 3 chemotherapies together, and over time that thought process has really shifted, and it really is what we're using in the metastatic space and most recently in the adjuvant space. So this study was touched upon earlier today, but this is a phase 2 study that was completed at MD Anderson and Mayo Clinic. It was a total of 60 patients. It was a single-arm phase 2 study in newly diagnosed patients with biliary tract malignancies. So it included cholangiocarcinoma and gallbladder cancer, for better or for worse. And in the initial start of the study, we were using ABC02 dosing of gemcitabine and cisplatin with nab-paclitaxel at 125 milligrams per meter squared added in as well. It was given on the same schedule of day 1 and day 8 of a 21-day cycle. Well, after 30 patients, we recognized that this was a myelosuppressive regimen, to say the least. And so due to the incidence of neutropenia and thrombocytopenia, we dose reduced, with gemcitabine decreased to 800 milligrams per meter squared and nab-paclitaxel to 100 milligrams per meter squared, and then a subsequent 30 additional patients were enrolled. The primary endpoint was progression-free survival, but we also looked at overall response rate and overall survival. And so these are the efficacy data that was presented at ASCO 2 years ago now. And as you can see in the evaluable patients, which was a total of 50 patients, the partial response rate was 34% with a disease control rate of 84%. Median PFS was 11.8 months. But what was, I think, striking and what caught everybody's attention was the fact that out of 60 patients, a total of 12 patients who had been discussed in a multidisciplinary format and were deemed to be unresectable were subsequently converted to resectable disease. Those patients, that 20% of the population, went on to surgical resection, and 3 of these patients actually had a pathologic complete response. So that, of course, raised eyebrows and got everybody excited. This is the waterfall plot where you can see that while we did not have partial response rate of higher than 34%, a large percent of these patients demonstrated some sort of clinical benefit to the triplet regimen. This was the PFS, as I said, 11.8 months. And this was our OS data of 19.2 months. So based on that, as has already been alluded to earlier, we have moved forward with a randomized phase 3 study through the NCTN with SWOG leading the charge. This is SWOG 1815. This is a randomized phase 3 study of gemcitabine and cisplatin compared to gemcitabine, cisplatin, and nab-paclitaxel in newly diagnosed patients with advanced biliary tract cancers, so locally advanced and metastatic both. Patients will be randomized 2 to 1 and restaged every 3 cycles. The primary endpoint for this study will be overall survival, and secondary endpoints are going to be looking at other efficacy as well as safety and CA 19-9. And then, of course, patients, we are going to be collecting blood and tissue samples and hopefully be able to get a better sense of the molecular characteristics of these patients over time as well. So that led to the study that Dr. Maithal referred to earlier today through the ICRN. And this was a study that basically stemmed from those 12 patients that caught everybody's attention. And this is a study for neoadjuvant gemcitabine, cisplatin, and nab-paclitaxel. It's really a feasibility study to start, and it's looking at the ability to take patients who do have this high-risk intrahepatic cholangiocarcinoma and looking to see if it increases resectability rates, improve recurrence-free survival, and overall survival in these oncologically high-risk patients. So he already kind of went over these objectives, but, you know, as I mentioned, the real question is feasibility, as well as safety and you know, and the ability to look at recurrence-free survival and overall survival. And importantly, I think it's great that they're going to be collecting blood and tissue biomarkers here as well, so we can really get a sense of those correlations that I was talking about. These are the parameters that they're using to define what they're calling these high-risk patients. And so again, I mean, it's technically patients that they're describing as larger tumors, multifocal but in the same lobe, or satellite lesions confined to the same lobe. And so this is that patient population that we're describing right now. These perhaps what you would describe as not patients that you want to take to the operating room right in the initial at the initial presentation. And then these are other standard inclusion criteria and exclusion criteria. So they are using the regimen that we studied in the phase 2, or the one that we found to be more safe, if you will, with the lower dose of the nab-paclitaxel and the gemcitabine. And they're going to be doing the 21-day cycles for a total of 4 cycles, followed by restaging. And if patients are eligible, then they go on to surgery. And the adjuvant therapy will be at the discretion of the treating physician, which, if we are to follow guidelines now, should be or could be capecitabine. And as I mentioned, they'll be collecting blood and tissue. So there are 34 patients planned, and as was said earlier, 3 patients are on this study for now. This is opening up at multiple centers across the United States, so hopefully it will accrue steadily. And they're looking at the safety and tolerability, as well as response, as well as recurrence-free survival and overall survival. So there are a number of institutions that are participating here, and hopefully we will have a sense of what this triplet regimen can do in the neoadjuvant setting, hopefully in the next few years. So what about beyond that triplet regimen? Are there other neoadjuvant studies going on? Well, surprisingly, there's actually not a lot. On clinicaltrials.gov, I was able to find 3, and the reason I put up that map in the beginning is that, importantly, some of these are happening in Thailand and China, where you know, we had the opportunity to visit a hospital in Shanghai last year, and then just the pure volume and the surgical experience in this part of the world, I think, is immense and is a ripe opportunity for neoadjuvant trials. So in Thailand, there is a phase 2 study that is going on in the Khon Kaen province. It is for 25 patients, and again, this is kind of a chemointensification. Patients are receiving modified FOLFOXIRI for 6 cycles, and what they're describing as borderline resectable cholangiocarcinoma. Their primary endpoint here is overall response rate, and this study is open and accruing currently. In China, there's a phase 1B/2 study that is looking to accrue 20 patients. This is with a PD-1 inhibitor that's kind of in a perioperative approach in patients who either have resectable intrahepatic cholangiocarcinoma or hepatocellular carcinoma. And their primary endpoint is actually pathologic complete response. And this study has been approved but has not yet started accruing. And then there was actually a study in the U.S. Out of Mass General that was a pilot study. Originally, 48 patients were planned, and this was actually looking at gemcitabine and cisplatin for patients who had resectable intrahepatic cholangiocarcinoma. In those patients, they received gem-cis, and then hopefully went on to surgery. They also were planning a cohort of gemcitabine of patients with unresectable cholangiocarcinoma who received gemcitabine and cisplatin, and then were given the opportunity for radiation. Their primary endpoint was going to be the number of patients who had postoperative or radiotherapy-related complications. This study was terminated, and I couldn't really figure out why, other than perhaps maybe just low accrual. So instead of 48 patients, it really only had 3 patients. One patient was resectable, received gem-cis, and went on to surgery. And then there were 2 patients in the unresectable cohort. One patient actually had progression during their gemcitabine and cisplatin and did not receive radiation, and one patient did receive radiation. So I would be remiss to discuss neoadjuvant approaches to locally advanced disease without just reiterating a point that I think has been beaten into your heads excessively today, and that is that this is not one disease. And so should the neoadjuvant approach be one approach? And I think that's the burning question, and is the question in advanced disease as well as in localized disease. These are clinically heterogeneous. We've already seen there's varying etiologies and different presentations and complexities depending on the location. And we've seen time and time again that sequencing has shown how different parts of the world, we're looking at different molecular phenotypes as well as anatomic differences in terms of what are commonly seen in intrahepatic cholangiocarcinoma versus extrahepatic. Additionally, as was alluded to earlier in the FGFR story, we also know that things like the FGFR fusions have an overall better prognosis. So the other questions become, should we be thinking differently about these patients in terms of prognosis when we approach them from a surgical resectability standpoint? Is there a certain type of aggressiveness that we should be utilizing in a subset of these patients versus patients who have, for instance, a KRAS mutation and we know seem to be worse players, if you will? So again, we've seen some of these graphs today. The BGJ398 story as well as the AG120 story for FGFR fusion and IDH mutations. And as was said earlier, these response rates in these refractory patients was not excessively high, but definitely, enough to raise eyebrows and to get people excited in this advanced patient population. But at the end of the day, the partial response rate in the phase 1 study of IDH mutation with AG120 was 5%, and 56% of patients had stable disease. Similarly, it was 19% in the BGJ study. So then, of course, that begs the question, should and could targeted therapies play a role in neoadjuvant therapy? And I think the other question is in these patients who have locally advanced disease or perhaps a little bit more oncologically high risk, as our colleagues have called it, what can we do in patients who have a known FGFR fusion or an IDH mutation with drugs that perhaps are a little bit more cytostatic? So something that has a partial response rate of 5%, well, if you have an IDH mutation, should we be using IDH inhibitors in the neoadjuvant setting in somebody that has locally advanced disease? I don't know that we really would see the dramatic responses that we would hope to convert patients with that sort of response rate, at least in the advanced setting. So in terms of future directions, I think we are all eagerly awaiting the results of the ICRN neoadjuvant study, and the question of chemointensification, whether it be gemcitabine and cisplatin with the addition of nab-paclitaxel or modified FOLFOXIRI, or even gemcitabine and cisplatin in a neoadjuvant, in a properly designed neoadjuvant study. I think the question of radiation, does radiation play a role in downstaging disease? Well, I think from the last presentation, I think it is safe to say that there is probably a role for radiation. Again, I think we need systematically designed trials to better answer that question. And then the last question is it isn't really one size fits all. So then how should we be differing our approaches? Should we be differing it based on anatomical differences, or should we be utilizing different approaches based on molecular profile? And should we let prognostic implications affect our decision-making processes in the neoadjuvant space? And if response is needed, are there certain targets that are better? We saw that beautiful waterfall plot from the ROAR study. In patients who have a known BRAF V600E mutation, are these patients who could potentially be converted to resectable disease with dabrafenib-trametinib combination rather than gemcitabine, cisplatin, and nab-paclitaxel? I think these are all the questions that are remaining to be answered and hopefully will be, especially as we get a better sense of what these drugs are doing in the advanced setting. We can safely move them into the neoadjuvant space and better define what the individual approach should be for a patient with locally advanced disease. With that, I thank you.
Thank you very much. We have a few minutes for opening questions. So let's put it, my questions will be, if the patient have something like FGFR fusion and is locally advanced, would you consider neoadjuvant as the targeted therapy versus the chemotherapy?
Yeah, I mean, I think that's a great question. I mean, I think The short answer is that most of these patients we identify after we've started them on chemotherapy, and so they're receiving a gemcitabine platinum combination when we realize that they have an FGFR fusion. I mean, I can tell you that what we would frequently do, you know, as a multidisciplinary group at MD Anderson is we would start these patients on our therapy, and whether that therapy was gem platinum or they were on a clinical trial with gemcis nab-paclitaxel or a clinical trial with an FGFR inhibitor. I mean, when and if we saw the response that looked like we had converted somebody to a potentially resectable tumor, we would bring them back to our tumor board, have a multidisciplinary conversation, and talk about resection. So, I mean, I don't necessarily think that we know enough yet to say absolutely we should be putting you on an FGFR inhibitor because that will convert you to a resectable patient. But we do feel comfortable putting patients on those inhibitors now, and if we start to see responses that make us think like that, then absolutely we should be representing them at our multidisciplinary conferences and having those conversations with our surgeons. And I do think that prognosis should make us think perhaps a little bit more about being more or less aggressive depending on what molecular alteration the patient has. I think it's reasonable to start asking those questions.